on this before, but a long time ago. And you specialize in ADHD. You are also GP. That's how we connect with each other.
Yep.
Do you want to say anything else about your role? I guess you've co-founded this amazing service here in Cambridge, CamADHD. Do you want to say anything about that?
Sure. So what makes the service really exciting to work in is that it's a partnership between a GP and a consultant psychiatrist. Okay, so we've got the best bits of both clinical specialties feeding into the service. And we're very much a GP-driven service, so we're psychiatry-led and GP-driven. Our GPs do the most of our clinical work. So that's the first big thing, which is kind of unusual on the national stage. The second thing that's really fun is that we have a fantastic SEND consultant who leads a full SEND team within the practice. So she's 20 years experience as a SEND. Most of that time has been focused on neurodiversity. She's deeply enmeshed in ADHD and autism, particularly, and dyslexia. And so she provides this amazing service, which makes us unique compared to others. She's so tuned in really to ADHD and autism that we actually use her to do our under 12 screening consultations, because she has the extra advantage that she actually can be screening for specific learning deficits all at the same time.
Well. Amazing.
Yeah. So that's been a change since we last spoke.
And I guess now you've got your lovely new premises as well up at Stowe Cumquay.
Yep.
Still see people in central Cambridge as well? Do you still at Homerton?
We are currently at Homerton, and we will be nearby, if not in Homerton. And the choir premises, the refurb is nearly complete, so we'll have 4 consulting rooms there. So it's very, very exciting. Yeah.
And you doing online as well as face-to-face?
Yeah, so we unlike many other services, we like to offer the face-to-face option. Okay. So what we like to do is to make sure that part of each assessment at least is done face-to-face. So we have the option of face-to-face, and that just absolutely suits some people, and that's absolutely what they want, but we can cope with online as well. Either is fine.
Super. So I wanted you to come back on just because it is nice to chat to you anyway, but I felt like I was getting a lot of questions. I'm going to make this about children, this conversation. I think we did more about adult last time. So I'm getting a lot of conversations from parents of children who are concerned about their children and are in that world of what do I do in terms of getting my child assessed? Because we keep hearing about how massive the waiting times are on the NHS to get these assessments done. What is our waiting time currently? Do you know?
It's actually a very complicated question. It's very difficult to answer because there's a certain amount of randomness to that. So yes, I mean it's slow through the child service, and of course, if there's big risk factors or difficult things happening in the family environment, they sometimes get fast tracked, but often not. There's also right to choose as an option.
Yes,
you can go through your GP. Both referral to local CamADHD and also right to choose involve hurdles, and people get stuck on the hurdles. And the right to choose offering varies massively. If they add a new right to choose provider, you may get lucky and get an assessment really quickly, but far more commonly people wait for ages, like another year or something like that. And then one of the other issues that drives us slightly potty with right to choose is that there doesn't seem to be a link between diagnosis and treatment in the contract. So people will get diagnosed and then be told there's a 9-month waiting list for treatment. Because that's done by a different team. Whereas if you come and see us, we have a slightly different viewpoint, really. We will start with a needs assessment, which is global and not diagnostic focused. And if you're on a limited budget and you're thinking, my child needs something and I don't know what, then there's several things you can do that are low budget. One is there's a really excellent charity called Pinpoint locally that supports parents whose children are having difficulty with their schooling. There's another one called Red Hen, which I know about, which has a similar sort of slightly non-diagnostic approach, seeing what's actually going on and what actually needs to happen. If you think
they link with parents, they link with the school for you as well, or is it very much a parent going to that?
Parents go to that, yeah. So we don't work with them directly. So these are things that the parents can go to in a low-budget kind of way, just to get a better sense of what's going on and simple things that could help. If they are fairly clear that there's a neurodiversity angle going on, they can have a good look look at our website. And we also, if there are specifically parenting questions involved, which are not to do with the diagnosis, but more to do with the parenting, our SEND consultant also does some sessions, which are basically guided parenting conversations in a sort of small group seminar scenario. Okay.
Yeah. Because I think I guess whenever we were having the conversation in the adult world, we have the ability, I guess, to make that choice around medication, not medication.
Yeah.
I think a lot of parents can see children struggling, but would feel uncomfortable around medication still. And I know you're really pro medication because you see firsthand the difference it can make. I mean, do you want to put that in there in terms of what you see the benefits of medication being? And then
sure. So, I mean,
other things that are separate. Yeah.
Just to backtrack slightly, I mean, we do a screening consultation so that we're sure that we're doing the right assessment, and we don't book a clinical assessment without seeing anybody first, and also without doing a whole pile of questionnaires. So we get all the data in and then make an offer as to what we think would be a worthwhile assessment consultation. And we can support people with an autism diagnosis, and we can do all the sort of SEND stuff if they actually need ed psych or a dyslexia assessment. We can sort all of that out, and often we'll do that even in parallel with a diagnostic assessment. But if for example they need an ADHD assessment, then it's important to recognise that let's fast forward now to a situation where we have a child who's struggling in school who's got ADHD. Basically there's two big sets of things you can do. You can do non-medication interventions, and you can do medication interventions. Now, a lot of parents have laboured long and hard by the time they get to us, and they've already done most of the non-medication interventions. And it's pretty much a waste of time trying to do psychological interventions with somebody who can't concentrate. It just doesn't work. And that's why some of the other strategies that would work for a neurotypical child just don't work in ADHD. So medication's absolutely fascinating because it works now. It doesn't work in the future. But what it does now is allow children to engage with the non-medication approaches. Okay. So you have this symbiotic relationship where you don't just stop the non-medication stuff and do the medication. You do both in parallel.
Together. Yeah.
Medication enables a whole bunch of things to happen at once, for them to listen and to reflect for longer, to actually try some maneuvers to help improve their functioning, to do better in school, to feel happy about doing better in school, to be able to manage their friendships better, to be better emotionally regulated, so that the children will feel the benefit of medication. There are side effects of medication which are highly manageable because we've known about these for a long time. The medication we use most often was actually invented in 1953. And nothing better has been invented since. It is absolutely fantastic. And if you can manage the diet and get the dose right, so you're treating the symptoms at a level where there's good effect and not too many side effects, then really there are far more problems associated with undertreatment than there are with treatment. Okay, and most of us work in this field because we've seen the benefit that magic beans can bring. It's usually how I describe them to children. So medication is not for life if you get people in childhood, and can help them to manage themselves better, to drive themselves better, and to actually reduce the gap between their actual potential and their performance. Because if you can get them through their formal education, being able to have a better sense of learning how to study and learning how to solve a difficult problem, and actually how to do something that's boring, even when it really, really is. If they can learn how to do that in school, and they choose the right career path based on good understanding, then actually once they hit the workplace, their need for medication plummets. Because they're doing what they're interested in. They're not trying to pack in facts that somebody else says is important anymore. They're just cracking on and doing what they do. So we really, really enjoy treating people fairly proactively in their education, is knowing that the better you manage that, the lower the needs are later. And there's now been evidence coming out that actually confirms that that's the case. It's just starting to come up. It's just instinctively obvious to those of us who are in the game. So we're very pro-medication, but it's not the whole story.
And in terms of the other strategies, what is in your mind when you're thinking about other strategies that can help? And hearing you say that they're more likely to work, or you'll benefit with the medication to enact them. But what's on your kind of list that you often end up?
I mean, it starts with a sense of, what actually is the core issue in ADHD, and it can be described as executive dysfunction, which means the bit of your brain that organizes both yourself, your activity, your behavior, etc., and also your thought processing just doesn't work so well. And so that comes out in a variety of ways. I mean, some people are actually absolutely hopeless with looking ahead and scheduling things. A really, really obvious one, and a very easy one to start to address, is a thing called time blindness. It is often said in ADHD that there are only two moments in time. There's now and there's not now. If I don't have to do it now, I'm not interested. And so kids with ADHD will only be focused on the now. And so what that means is, because they're never reflecting on it, they never actually get a sense of even how long a minute is. They just don't know. It's either now or not now. So you can do some basic gamified maneuvers to just see if you can stretch their awareness of that. Now, they generally know how long a lesson is in terms, or even if they don't, they're in them, and they can learn to start to tune into that. If you give them an exercise to do, can you race around the garden and pick up all the toys and do it as fast as you can, and how long do you think that will take you? You get them to estimate in advance. You time it with a stopwatch. You get them to guess how long it took after they've done it, and then you actually look at the stopwatch. So for the same activity, you've got 3 time-checky moments, and they can learn to synchronize. Now, Claire, you and I are GPs who spent a lot of time in the NHS. We have a very finely tuned sense of how long 10 minutes is.
Yeah.
Because that was and just like me, I'm quite sure that 10 years ago, you kind of knew if you were in the 9th or the 11th minute of a consultation. Okay. And that's partially just practice, but it's actually about aware practice. Because if we never looked at the clock, we'd never know. If we never got behind in our patient list, we'd never know. And the trouble with the kids is, can you come down to dinner in 5 minutes, please, to an 8-year-old with ADHD? It's absolutely hopeless because they don't know what 5 minutes is. And it's not now. Right. So it's a much better thing either to have, say, a countdown clock where it has a visual marker, and you're going to put a 5-minute thing on, and they can watch that happening. Or you can say, I'd like you to come down at 2 minutes to 7. It's 6:58, and you write it down, and they're looking at their clock and they're doing the maths, and they actually will come, they'll be late, but they might get down for 7 o'clock. So actually giving them a fixed time to aim at, or watching the passing of time, is effective. Whereas actually with a neurotypical child who proudly walks around, playing with his watch, if you say to me 6:57 for dinner, he'll probably do that. Whereas an ADHD kid is just not looking. So you have this blindness to time, just as if you have a
and is that also just that there's a more definite instruction there that feels like it's more clear and straightforward, as opposed to opening up a bit of a minefield in terms of what your brain will do with
it needs to be precise. So you can't talk about relative time, because there's only now and not now. So you either have to demonstrate the passing of time, or give a time target for them to count down to. So if, for example, you said, can you come down to dinner at 7 o'clock? And what's the time now? It's 6:52, right? Then why don't you set a minute timer? And they watch it come down. And so when it goes off, it's not a shock, because they've sort of been starting to think about it as they go along. So that's just time management. There's lots of other ways you can gamify the process of becoming more
aware of time.
Getting kids to do an admin task in a certain way. If getting them to do it in one way doesn't work, find another and help them along, and do the first one with you, because sometimes they need to see a worked example.
It's that kind of thing of having more than one stimuli, isn't it? Or like the visual and in text kind of thing can be really helpful, rather than having just there's that sort of 2 kind of representations, and that helps as well, doesn't it?
Exactly. So rather than saying come down at 7, you write 7, and you have the visual backup of the timer going down, and that's visible to them, or the analog visual counting clock.
And I guess I'm obviously sort of lifestyle medicine, hattish world as well. I often go into the, being fit and active and being outside, being cautious around. I mean, what do you think's got the most science behind it in terms of that kind of stuff, like avoiding too much sugar, dietary type things, making sure you're sleeping? Is there anything that really sticks out for you? This is something that actually I end up saying to all my parents, because this is
basically
the end of the child.
most ADHD, and particularly boys, they need running. There's a brilliant
activity.
All dogs have ADHD, and we have to walk our dogs. It's a bit the same with kids. If they don't get to run around and expend some activity, then they're more likely to be struggling to concentrate or not get to sleep. Okay, so exercise is really key. Long-acting calories are important, or slow release calories. So sugar with sugar levels shooting up and down again, it's bad for all of us, as you know. It's just in ADHD. It's nothing unique to ADHD. It doesn't cause ADHD. It just makes it worse if you've got it. And people with ADHD tend to make poorer food choices because they tend to go for a short term. I like that. I'll do it. There's not so much long term planning. So they need guiding towards with extra input towards good food choices. So that's exercise. That's diet. Sleep. There's nothing quite like routine. The thing about kids with ADHD is they struggle to build routines. Okay, so the classic example is you'll get a kid who's just always late for school, and the parent will go into the room and see what they're doing, and they put one sock on, and they're holding the other sock, and they're wondering what to do. Okay, because the routine isn't there, and they've got distracted by a thought. Okay, so a really simple thing you can do there is get them to figure out what do they need to do on the way to school. Between when they get up and when they go to school, what do they need to do? What order would they prefer to do that in? What works for them? And try it for a while, and if it doesn't work, then change it. But then get them to write it out and put some time markers on it. You need to have got your socks on by X, and you need to have a clock. So they're learning their time awareness and they're learning their sequence. And you actively have a conversation about changing the sequence according to what they want. Make it all about them and what they want. And so they're driving it. And then they have the possibility of learning a routine. Because as you know, I can say A, B, C, D, E, F, G, as with tasks that are run in a row, if you get used to A follows, B follows A and C follows B, etc. So if you do them all in the same order, it's kind of effectively like one thought process that sets off this kind of macro command thing where everything follows. And because they keep getting distracted, they're constantly seeing it as kind of 10, 15 different things that need doing. Whereas actually just
want to make it almost one thing because they all link together.
So routine, getting up at the same time, doing stuff in the same order, getting the breakfast in, and pills with it. Sometimes we actually medicate people before they wake up, so they wake up with a clearer head and just get on with it.
How does that work?
Oh, it's fantastic.
Teaching people tablets while they're sleeping.
Yeah. So I actually did this with my son because to me it was just obvious, and then I discovered it was a thing, and it's called the double alarm technique, and it worked really, really well. And I'll give you a brilliant example. I had a kid who was 12 or 13, he was in year 7. He'd done a term at school. He was completely overwhelmed. He couldn't cope. He was lying in his bed going, I can't do it. Okay, because as soon as he got up, he couldn't figure out what to do. He got overwhelmed. Okay, so we chatted with him about it. We started medicating him, had a chat with his mum, and we agreed that 45 minutes before she wanted him to get up, she would give him this medication. So he sits up, swallow the pill, here's your water, see you in 45, job done. Kids cope very well with going back to sleep in those circumstances. And then when his actual alarm goes off, he can cope because he can think straight and he's got his list on his wall and he just does it. It completely transformed the morning routine. The best bit is in the second month, he would stand at the door and he'd say to his mum, come on, we're going to be late. And then they stopped doing it because it wasn't required anymore. So the double alarm technique is a really, really good way of, getting them through
starting the day, because often that's the bit that if the day doesn't start, then the whole day is messed up, isn't it? I'm really aware of time. I knew this was going to happen because this is a really massive topic, and just throw in at the end for me. So the question, and I put this to you beforehand as to what we were going to do, and we haven't talked about it. So the questions I'm being asked is, if someone comes for a private assessment of ADHD, will the school accept it? Because I've been told that they won't, but you said to me very clearly beforehand they will.
We've never had any issue with schools.
Never had any issue. So they have to kind of step in and they have to get that child the help that they're requiring within that school environment if they have a diagnosis.
Absolutely. I mean, there are several issues here. A, we're private, and B, we're GPs. So the JCQ is the national organisation that actually defines, who gets extra time and so on in exams. And actually, last year they put in a new section about GPs being part of the group of people who can diagnose ADHD, which is really interesting. And it wasn't very well written. It actually had some errors in it, and so we worked with them to edit it to make it clear. So that was really, really good. And the other thing that they have said is that, they strongly suggest that people have a QB check as part of their diagnosis. So, for example, the local sixth form, the elite sixth form college in Cambridge now makes it mandatory. They won't accept an ADHD assessment that doesn't have a QB in it. The quantitative behaviour check, that's the one I showed you at that morning meeting a year or two ago. So we
for
just
anyone listening, it's like a computer-based kind of test.
It's a computer-based performance test that actually standardizes their response to a hypothetical situation, which is basically designed to elicit the features of ADHD. So rather than saying I've got these ADHD symptoms, or the parent saying he's behaving like he's got ADHD, they actually perform. They actually are actually acting innocent. Well, they're doing what they normally do. They're following a set of instructions, and this is the best commercial test on the market. It's been around for a really long time, and we just absolutely regard it as incredibly helpful in our assessments, as do
so we've got a world where the school is saying that needs to be done.
Yeah, Hills Road says that if it's not in the assessment isn't adequate. That's the only feedback we've had from schools.
And in terms of who gives that test, I know you guys do. NHS assessments would do.
Many, not
some
all.
Places that won't. Some psychologists who say that they'll do diagnosis presumably don't do it.
Some
being careful around that piece, maybe.
Yeah, I don't know whether psychologists have had assessments rejected on it, but the school have told us it's mandatory. The NHS tends to do it most often. I'm not sure if all of the time. There's a subtle difference. There's a QB check, which is you can do online from home, the QB test that they do in the clinic. It's all the same software and the same algorithms. So it's equivalent, essentially. It's just the one we do is more convenient for our patients. It means you don't have to come to the clinic for that extra time.
Okay. And then really, lastly, I guess it's that thing about how we know there's a diagnostic type world and then there's maybe a treatment world. How willing are local GPs to pick up prescriptions whenever the assessment has been done by a private setting? How are you finding that locally?
It's a tough world because, as you and I both know, the GPs have a very, very difficult contract to work under that asks them to do a whole bunch of stuff that is not paid. Okay, so the problem with ADHD compared to those other things is the evidence that ADHD treatment is effective is just phenomenal. The massive impact on lifelong lower risk of bad things happening, and also much better education achievement if people can lock in at school. A lot of GPs are starting to really get their head around that, but they're being encouraged to not share care with private services until matters are clarified further. So it is a bit of an uphill struggle, and we can't twist their arm. It's their choice. But what we're trying to do is work locally, closely with local GPs to make sure that they understand the benefits of treatment as much as possible. And as GPs running the service, as me running the service, my goal is to make the shared care process with our local GPs as effortless as possible for them, because I'm being paid to do this, they're not. And so we get the patient actively involved. When they ask for medication, we ask the patients actually to send in observations so the GP doesn't have to pull them in to do them. We try and make it really, really clear. We're trying to communicate with them at the right time. We try not to send the letters they don't need to act on, which just fill their headspace. So we try and think about what we like from their perspective and make it as easy for them as possible.
Okay. But I'm hearing there's still an issue. That's a work in progress, I'm hearing.
It's a national issue. Okay. Yeah.
Super. I'm going to wrap up because that's well over the 15 minutes and I know you've got other things to do, but it may be that we continue this conversation. Thank you so much for coming on. And if anyone's got any questions, please feel free to message me and I can connect you with Chris. Thanks a lot.
Excellent. Thanks, Claire. Cheers.